Good evening, friends. Today we have one case to discuss. We will discuss intra-abdominal infection. So our patient, 51-year-old female patient, who is a known case of hypertension, systemic sclerosis, rheumatoid arthritis on medication, and she has history of past history of GBS in 2018. Now she presented with history of abdominal pain since 4 days, multiple episodes of loose motion and vomiting. On arrival in emergency department, patient was vitally stable. So on arrival in ICU, her pulse was 72 beats per minute. Blood pressure was 130 by 80. Respiratory rate was 19. Saturation was 100%. On CVS examination, S1, S2 present. RS, air entry equal on both sides, clear. Per abdomen, which was soft, diffuse tenderness was present. And CNS wise, patient was consciousness. In view of persistent abdominal pain, we did CT abdomen, which was suggestive of perforation in the ileum. This was the CT of that patient. So immediately this patient has taken for emergency exploratory laparotomy with right hemicolectomy and end ileostomy. So total blood loss was 300 ml. Intake was around 1.5 liter, output 400, and she received 1 PRBC. So these are the intraoperative findings, which suggested multiple perforation into the distal ileum, perforation in the cecum with the fecal peritonitis, then infected collection in the pocket over the right paracolon gutter, then frank pus was present, perforated in the diseased intestine, then edematous large intestine was present, and there was a poor blood. So the patient was maintaining blood pressure of 5 ml blood pressure with 5 ml per hour of the noradrenaline, which was started, and then she was started on injection meropenem 1 gram, injection targocid 400 mg, injection flucon 400 mg, and the patient urine output was adequate, but ABG showed the lactates of 5. Then on repeated ABG, her lactates were persistently on the higher set. And when blood investigation came, her blood parameters were totally deranged because HB showed hemoglobin of because it showed the hemoglobin of 5. Platelet became 85,000 and INR was prolonged, so that was 4.75. So clearly we can interpret from this parameter that patient went into disseminated intravascular coagulopathy, and in view of very low hemoglobin level, she received 10 point cryoprecipitate, 6 point FFP, and 1 point PRBC. And in view of persistent lactic acidosis, because when we did the serial ABGs, her lactates were persistently high. So in view of that, the early slide was initiated. So blood pressure was persistently falling. So NORAD was increasing and vasopressin was added. So TG-cycline was added here empirically in view of an intra-abdominal infection, and the flucon was replaced by Iraxis, so that is Anidulafungin, in view of hemodynamic instability. So this is the ECG and the USG abdomen pelvis for this patient. Because of the severe drop in hemoglobin, we started suspecting of any intra-abdominal bleed. So we did the USG abdomen pelvis, which came out to be normal. So there was no intra-abdominal collection for this patient. So the current issues for these patients are intra-abdominal sepsis, acute kidney injury, DIC, and septic shock. So next day, the patient underwent SLAT again. The lactates were reducing, platelet counts were low, SDP was transfused, blood culture showed Serratia marcescens, which were GNB. So we continued with the meropenem and we stopped targocid. NORAD was going on at 4 ml per hour. Blisters were present all over the body. Empirically, still, since Serratia marcescens was a gram-negative organism, we continued with the injection meropenem, then injection poly B we continued, and then injection tigecycline for intra-abdominal infection. which was already started on empirical basis. So on 9th of January, her labs were HbA came out to be 10. Then platelets were persistently dropping. That was 19,000. Then her SGOT was elevated. That is 1,960. SGPT was 304. ALP was 150. On 10th of January, the patient underwent SLAD. The patient was conscious, obeying command when given off sedation trial, and she was kept on dobutamine support of 4 ml per hour. Adrenaline was going on at 2 ml per hour and continued on the same antibiotic. On 10th of January, again when we rechecked her lab, her platelet was still low, which was 11,000. Then her SGOT was still on the higher side, that is 2,149. INR was still increased, that was 2.31, and SGPT was 394. So on 11th of January, patient was conscious, intubated, but she was conscious, obeying when we gave off sedation trial. Extremities were cyanosed and ischemic. Dry gangrene was there. BP started falling. Hence, again, NORAD was started. Rheumatology reference was given because she was already known case of systemic sclerosis and rheumatoid arthritis. So they suggest the possibility of the catastrophic EPLA. So again, we have taken the opinion of hematologist for starting IVIG. So platelet transfusion was given in view of low platelets. So separate criteria was applied here for diagnosing EPLA, which was a clinical in this. The clinical criteria include vascular thrombosis, then pregnancy morbidity, which is a death of normal fetus at a more than or equal to 10 weeks, premature birth at less than 34 weeks due to preeclampsia, more than three consecutive abortion at 10 weeks, and placental insufficiency at less than 34 weeks. And lab criteria includes anticardiolipin IgG, anticardiolipin IgM, and lupus anticoagulant. Then for definitive diagnosis of EPLA, one clinical and one lab criteria should be satisfied. So for this patient, that one vascular thrombosis criteria was fulfilled because she has the cyanosed peripheries. For satisfying this lab criteria, we have sent anticardiolipin beta to microglobulins. Then, in view of catastrophic alpha, we have decided to start her on IVIG at a dose of 400 mg per kg per day. And then again, her labs were reevaluated on the 11th of January. And her platelet count, as we can see, her platelet count was still on the lower side, that was 11,000. Then SGOT was 1,201. SGPT was 322. ALP was 299. Bilirubin level was 4.5. So her culture report came, and her blood culture showed the growth of Serratia marcescens. Peritoneal culture showed the growth of E. coli, Pseudomonas, which was meropenem syncytium. On 12th of January, when her reevaluation was done, her HB was still on the lower side, 8.4. Platelets were 29,000. SGOT 632. Bilirubin was 5.88. SGPT 193, and ALP was 213. So this was SSA-RO for this patient came out to be positive, and beta 2 glycoprotein levels were negative. So patient condition started deteriorating. Lactates were persistently high. Acidosis were worsening, and the patient went into cardiac arrest and could not be revived. So the fire. So from the case that we have discussed, the multiple perforation occurs because of the catastrophic abla, and for that, because of that multiple perforation, the patient went into intra-abdominal sepsis. And for that catastrophic abla, we have started IVIG. So we'll discuss in short how we will how are we supposed to manage this intra-abdominal infection. So, new sepsis definition. Sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to the infection. Septic shock is defined as if the patient requires application of the vasopressor to maintain mean arterial pressure of more than or equal to 65 mmHg despite adequate volume resuscitation, and if the serum lactate is more than or equal to 2 mol per liter. The clinical situation is defined as septic shock. The key points from the sepsis 3 definition. The concept of SIRS can still be used to describe systemic response to sterile hit, that is pancreatitis in trauma or an infection, and its appearance should trigger the screening for infectious foci. So sepsis is more than the inflammation. It is complex and life-threatening organ dysfunction resulting from dysregulated host response. So search criteria help to detect inflammation, inflammatory, and the infectious complication. There are other criteria like Q-SOFA and SOFA score, which these scores help in identifying septic patient and defining the need for intensive care. So we'll briefly see what is SOFA score. The SOFA score includes the component like PaO to FiO2 ratio. Minimum score is given if the ratio is more than 400. Maximum score is given if this ratio is less than 100. Then platelets are more than or equal to 1,50,000. For that, zero score has been given, and maximum score of 4 has been given if the platelet counts are less than 20,000. Then for the zero score has been given if the bilirubin is less than 1.2 or 1.2, and maximum score of 4 has been given if the bilirubin is more than 12. Then the next criteria includes blood pressure, which in this zero score has been given if the mean arterial pressure is more than 70, and maximum score of 4 has been given if the patient is on the triple inotropic support. So the next is GCS score criteria. In that, zero score has been given if the patient's GCS score is 15, and the maximum score of 4 has been given if the patient's GCS score is less than 6. Then the next criteria includes creatinine and the urine output. So zero score has been given if the creat levels are less than 1.2, and maximum score has been given if creat levels are more than 5, and urine output is less than 200 ml. So Q SOFA is easy to calculate, which includes only three criteria, that is alteration in mental status, respiratory rate more than 22, and systolic blood pressure less than or equal to 100. So pathogenesis and the risk factor for sepsis and septic complication. So it includes genetic factor, that is toll-like receptor polymorphism, increased age, and the acquired immunosuppression like cancer, medication, diabetes, and alcohol use. Then the risk factor for the anastomotic leakage include male gender, age, smoking, intraoperative hypotension, medication, and diabetes mellitus. Then pulmonary infections include coronary chronic obstructive pulmonary disease, prolonged intubation, aspiration, recent intra-abdominal and thoracic surgical procedures, urinary tract infection and urosepsis. It includes indwelling catheter, poor mobility, and female sex. So the clinical presentation depends upon the site of infection, while the general symptoms such as fever, tachycardia, tachypnea reflects the SIRS criteria. Additional signs include altered mental status, oliguria, change in skin with the elonged capillary refill time, elevated liver enzyme, pathological coagulation should be recognized on on everyday rounds. Now, what is the role of CRP? Typically, CRP peaks between postoperative day 2 and postoperative day 3 and declines to the baseline level of postoperative day 5. So the persistent elevation of the CRP can indicate septic complication in the postoperative phase. For colorectal resections and pancreatic surgery, We have defined the CRP level on post-operative day 5. For colorectal resection, it is 100, and for pancreatic surgery, it is 140. If Now the role of PCT has been controversially discussed in the various literature. So persistently increased plasma PCT levels are associated with the infection and septic surgical complication. It is ill-defined whether PCT can distinguish between SIRS and sepsis. The Captain trial revealed that none of the circulating biomarkers, including PCT, can discriminate better between sepsis and SIRS than CRP alone. Marker of when to end antimicrobial therapy, PCD guidance can reduce the treatment duration and even reduce the mortality. A PCT reduction of 80% of initial value or a serum value of less than 0.5 were the cutoff values for ending antibiotic treatment. Now, the ultrasound guided diagnostic drainage of the suspicious fluid collection combined with the therapeutic tube insertion on demand help to diagnose conditions such as intra-abdominal abscess, hematoma, and pancreatic fistula. A modern diagnostic approach, the measurement of intraperitoneal cytokines, might be another promising tool for defining and monitoring inflammatory reaction in patients. One suspect type, the CT scan, is a diagnostic gold standard for both secondary and ongoing peritonitis with diagnostic sensitivity of 97.2%. For secondary peritonitis, the peritoneal CT attenuation values can even predict hospital survival. Alternatively, the positron emission tomography scan could play the important role in further diagnosis of intra-abdominal sepsis, but is mainly restricted to septic foci of unknown origin or spreading multifocal bacteremia, that is Staphylococcus aureus. So, regarding therapy, early goal directed therapy and volume resuscitation are the pillars. So, the therapeutic principle of early goal directed therapy, which was first introduced by Rivers in 2001, postulated protocol based approach for treating patient with the septic shock. So the target for this therapeutic resuscitation were include CVP should be 8 to 12, MAP should be more than or equal to 65, urine output should be more than or equal to 5 ml per kg of body weight, and central venous oxygen saturation should be more than or equal to 70. Now there are three large multi-center randomized control trials, that is process trial, arise trial, and the promise trial, showed no benefit for protocol-based sepsis therapy in early resuscitation phase. EGD showed in early goal-directed therapy showed no 90-day survival benefit and no improved 1 year survival, but longer duration of ICU stay and increased vasopressin. So in case of hemodynamic instability, that is systolic blood pressure of less than 90 mmHg, MAP of 40 mmHg, or serum lactate levels of more than 4, the surviving sepsis campaign guideline recommended the rapid application of the crystalloid within first 3 hours after hospital admission. So many trials on fluids resuscitation are there which compared crystalloid versus colloid and could not show any benefit for the colloid solution. Instead, a colloid may be nephrotoxic, except albumin. Whether balanced crystalloid solution or saline solution should be used, it's still being discussed. So, compared with the saline, buffer crystalloid solution could not reduce the risk of acute kidney injury in critically ill patients. As reported previously, chloride restrictive balanced solution is in line with decreased rate of dialysis and renal insufficiency. This is being analyzed by the two ongoing trials, that is basic trial and the plus trial. New guidelines only recommended patient-oriented individualized volume substitution according to the patient's fluid responsiveness, which can be estimated by the passive leg rest testing. So, for example, the predictor of the inadequate fluid responsiveness are the heart insufficiency, hypothermia, deterioration of the gas exchange, increased serum lactate, immunodeficiency, and coagulopathy. So in 2017, showed volume overload in early phase of sepsis, presenting risk of increased mortality. So how fluid can be substituted in sepsis remains the matter of debate. While the guideline postulated substitution as long as the patient shows circulatory response and increased cardiac output. Now, the source control in intra-abdominal sepsis is based on the four important elements, that is debridement, removal of the infected device, drainage of the purulent cavity, and the decompression of the abdominal cavity. Now, the damage control surgery. The first operation should be performed as short as possible, followed by the secondary reconstruction of the gastrointestinal continuity or abdominal wall. Studies are required to define indication, timing, and techniques of damage control surgery for patients with the non-traumatic abdominal sepsis. In both trauma and intra-abdominal septic shock, severe intra-abdominal sepsis, the patient is threatened by physiological triad of coagulopathy, inflammation, and cardiovascular instability. So hospital mortality increased progressively from 25.4% to 56.1% in patients without or with severe sepsis associated with coagulopathy, respectively. So the cardiovascular instability with the concomitant high level of circulating catecholamine is associated with poor outcome and severe side effects such as myocardial injury and peripheral ischemia. From trauma surgery, the principles of abbreviated initial surgical approach for controlling intra-abdominal blood loss contamination lead to the accelerated resuscitation of physiology within the critical early phase after damage. So this damage control concept is being evaluated for intra-abdominal source control also. Now we will quickly see what are the components of this damage control approach in trauma surgery as well as in septic shock. In trauma surgery, the phase 0 includes initiation of the hemostatic resuscitation. Phase 1 includes identification of injury pattern and physiology. Phase 2 includes control of hemorrhage and contamination. Phase 3 includes reassessment during surgery. Phase 4 includes physiological restore on ICU, hemodynamic stabilization, correction of acidosis, hypothermia, coagulopathy, organ support, and phase 5 includes definitive repair, abdominal wall closure. In septic shock, the phase 0 includes preoperative resuscitation, warming, and antimicrobial therapy. It should be given, antimicrobial should be given within the 3-hour bundle. Then phase 1 include identification of patient's pathology and physiology. Phase 2 include decontamination source control. Phase 4 includes physiological restore on ICU, hemodynamic stabilization, correction of acidosis, hypothermia, coagulopathy, any organ support if needed, and specific individualized antibiotic treatment. So in contrast to damage control for trauma and intra-abdominal hemorrhage, the concept has been modified for intra-abdominal sepsis, especially in the pre-surgical phase, and there is growing evidence that the patient with a secondary peritonitis are benefited from damage control resuscitation phase prior to the surgical intervention, which is strongly recommended by Sepsis Surviving Campaign Guideline 2016. Now we'll see what is peritonitis. So peritonitis is classically classified into primary peritonitis, secondary peritonitis, and tertiary peritonitis. Primary peritonitis is diffuse bacterial infection without loss of integrity of gastrointestinal tract and the absence of identifiable source of infection during surgical exploration. This is rare and mainly occurs in infancy, early childhood, as well as in cirrhotic patients. Secondary peritonitis, the most common form of peritonitis. It is an acute peritoneal infection. This is resulting from loss of integrity of gastrointestinal tract and from infected viscera as occurred in our patient. And it is caused by perforation of gastrointestinal tract by the direct invasion of infected intra-abdominal viscera. For example, it might happen in gangrenous appendicitis and the perforated duodenal ulcer. The anatomical dehiscence are the common cause of secondary peritonitis in postoperative period. Now, the tertiary peritonitis is the recurrent infection of peritoneal cavity that follows either primary and secondary peritonitis. It is the complication of secondary peritonitis and may be termed as ongoing peritonitis and persistent peritonitis. So, the primary objective of intervention include determining the cause of peritonitis, draining fluid collection, and controlling the origin of abdominal sepsis. Now, the control of septic source can be achieved either by surgical and non-surgical means. Now, the non-surgical intervention procedures, percutaneous drainage of abscess when it is available. Ultrasound and CT guided percutaneous drainage of abdominal and extraperitoneal abscess. in selected patients are safe and effective. Surgical source control include resection and suture of disease and perforated viscous. For example, diverticular perforation, gastrointestinal perforation. Removal of infected organ, that is appendix and gallbladder. Debridement of necrotic tissue. Resection of ischemic bowel. Repair and resection of traumatic perforation with primary anastomosis or exteriorization of the bowel. In recent years, laparoscopy has been gaining wider acceptance in the diagnosis and treatment of intra-abdominal infection. So the laparoscopic approach in the treatment of peritonitis is feasible for many emergency conditions. It has advantage to allow at the same time adequate diagnosis and appropriate treatment with the less invasive abdominal approach. However, laparoscopy due to increased intra-abdominal pressure uh, due to pneumoperitoneum may have negative effect in critically ill patient, leading to acid-base balance disturbances as well as change in cardiovascular and pulmonary physiology. Now, antibiotic. So, blood culture should be collected prior to antimicrobial treatment. 2 to 3 pair of blood culture samples should be collected from both peripheral blood and from the central venous catheter. So any antibiotic therapy dramatically reduces the detection rate of blood culture technique. In 2016, Surviving Sepsis Campaign recommendation postulated that initial administration of antimicrobial should be performed within 1 hour after admission. And the first choice is always broad spectrum antibiotic or combination of the antibiotic. Antibiotic spectrum should be narrowed after microbes have been isolated. Based on the clinical situation, de-escalation of the antimicrobial pharmacotherapy should be considered as soon as possible. Now, the isolation of Candida species from the peritoneal fluid correlates with the impaired clinical prognosis and the persistent ongoing peritonitis. The European Society for Clinical Microbiology and Infectious Disease recommended echinocandins as the first choice medication for Candida infection in ICU patients. Fluconazole is the rational alternative for treating Candida parapsilosis. It is important to know that medication must be administered up to minimum duration of 14 days after Candida negative blood culture occurs. First, rapid detection of specific bacteria from intra-abdominal source would shorten the period of empirical antimicrobial therapy to tailor more specific one. In contrast to blood culture, PCR-based technique can allow the rapid identification of bacteria and associated antimicrobial resistance. Second, the antibiotic stewardship should be implemented in any surgical ICU. The rapid and individualized de-escalation of antimicrobial therapy avoids bacteria in hospital resistance and reduces the pharmacological adverse effects such as renal and hepatic insufficiency. Third, the differentiation between infection and the colonization is the major importance for surgical patients with peritonitis. These patients are permanently threatened by hospital-acquired infection. While colonization by multi-drug resistant pathogens such as MRSA, vancomycin resistant enterococci, or multi-drug resistant gram-negative bacteria are often diagnosed in surgical patients, and it normally leads to isolation only. So this is the schematic overview of antimicrobial therapy in community-acquired secondary peritonitis. So it divides the peritonitis into mild peritonitis, localized peritonitis, and diffuse peritonitis. So most common microbes are Enterobacteriaceae, anaerobes, and Enterococcus. So for mild peritonitis and localized peritonitis, the antibiotic of choice is as aminopenicillin plus beta-lactamase inhibitor, cefuroxime, cefotaxime, ceftriaxone plus metronidazole, levofloxacin, ciprofloxacin plus metronidazole, and moxifloxacin. If it is diffuse peritonitis, then we can give piperacillin, tazobactam, ertapenem, tigecycline, moxifloxacin, ceftolazone, and tazobactam plus metronidazole. For tertiary and ongoing peritonitis, uh, if it is caused by Enterobacteriaceae plus ESBL, anaerobe, Enterococcus plus VRE, Staphylococcus plus methicillin resistant Staphylococcus, then we can start with tigecycline, meropenem, plus linezolid, imipenem plus linezolid, ceftolazone tazobactam plus metronidazole, ceftazidime avibactam plus metronidazole plus linezolid or fosfomycin. Candida, if for candida coverage, we can add echinocandins. So empirical, now quickly we will see now what is the empirical antibiotic regimen for intra-abdominal infection. If the patient has normal renal function, if it is a community acquired intra-abdominal infection and the patient is non-critically ill, then we can start with amoxicillin clownate 1.2 to 2.2 gram every 6th hourly, or ceftriaxone 2 gram every 24 hourly, or metronidazole 500 mg every 6th hourly, or cefotaxime, 2 gram every 8 hourly plus metronidazole 500 mg every 6 hours. Or if the patient has beta-lactam allergy, then we can start with ciprofloxacin 400 mg every 8 hourly, metronidazole 500 mg every 6 hourly, or moxifloxacin 400 mg every 24 hourly, or in patient at risk of infection with the community-acquired ESBL producing Enterobacteriaceae, then we can start with ertapenem, 1 gram 24 hourly, tigecycline 100 mg initial dose, then 50 mg 12 hours. Now, the empirical antibiotic regimen for critically ill patient with community-acquired intra-abdominal infection and normal renal function. If the patient is critically ill, we can start with the pipera, but we are suspecting that it is a community acquired. Then we can start with piperacillin tazobactam, 4.5 gram every 6 hourly. Along with piperacillin tazobactam, no need to give metronidazole coverage because piperacillin tazobactam has already covered because it already has anaerobic coverage. Then if we are using cefepime, that is 2 gram 8 hourly, then along with that we can use metronidazole, which is 500 mg every 6 hourly. So if the patient has at risk of community acquired ESBL infection, then we can start with imipenem 1 gram every 8 hourly and doripenem 500 mg every 8 hours. Imipenem celestine 1 gram every 8 hourly in patient at high risk of infection with enterococci, including immunocompromised patient and patient with the recent antibiotic exposure. Consider use of ampicillin 2 gram every 6 hourly if the patient is not treated with piperacillin, tazobactam, or imipenem celestine. Empirical antimicrobial regimen for non-critically ill patient with healthcare associated intra-abdominal infection, that is normal renal function, healthcare associated, and non-critically ill patient. Then we can start with directly piperacillin tazobactam 4.5 gram every 6 hours. In patient at high risk of infection with the multi-drug resistant organism, including recent antibiotic exposure, patient living in nursing home or long stay care with indwelling catheter and post-operative intra-abdominal infection, then we can start with the meropenem 1 gram every 8 hourly plus ampicillin 1 gram every 2 gram every 6 hourly. Then doripenem 500 mg every 8 hourly, or ampicillin 2 gram every 6 hourly, or imipenem celestine 1 gram every 8 hours. If as carbapenem sparing regimen, then we can use the piperacillin 4.5 gram every 6 hourly, tigecycline 100 mg initial dose, then 50 mg every 12 hourly. If the patient is at high risk of invasive candidiasis, then fluconazole 800 mg loading dose, then 400 mg every 12 hourly. In patient with the documented beta-lactam allergy, consider antibiotic combination of amikacin, that is 15 to 20 mg per kg every 12 hours. Now, what is the empirical antibiotic regimen for critically ill patient with healthcare associated intra-abdominal infection? So considering the patient has normal renal function, this infection is hospital acquired, and on top of that, if our patient is critically ill, then we can start with meropenem 1 gram every 8 hourly, doripenem 500 mg every 8 hourly, imipenem celestine 1 gram every 8 hourly. And in the Carbapenem sparing regimen, ceftolazone tazobactam 1.5 gram every 8 hourly, plus metronidazole 500 mg every 6 hourly, or ceftazidime avibactam 2.5 gram every 8 hourly, plus metronidazole 500 mg every 6 hourly, vancomycin 25 to 30 mg per kg loading dose, then 15 into 20 mg per kg dose every 8 hourly, ticoplanin 12 mg per kg 12 hourly, 3 times loading dose, then 12 mg per kg every 24 hours. In our patient at risk of vancomycin resistant enterococci, including patients with previously enterococcal infection or colonization, immunocompromised patient, patient with long ICU stay, recent vancomycin exposure, then we can use linezolid 600 mg every 12 hourly, daptomycin 6 mg per kg every 24 hourly, plus we can give invasive patient plus in patient who are at a risk of invasive candidiasis, then we can add echinocandins like caspofungin, 70 mg loading, then 50 mg daily, anidulafungin, 200 mg loading, then 100 mg daily, micafungin, 100 mg daily, then amphotericin B liposomal antibody, that is 300 mg per kg per dose every 24 hours. In patient with the suspected or proven infection with the MDR Pseudomonas aeruginosa, consider the use of antibiotic combination with ceftolozane tazobactam. In patient with suspected and proven infection with the carbapenemas producing Klebsiella pneumoniae, consider the antibiotic combination with ceftazidime avibactam. In patient with the documented beta-lactam allergy, consider antibiotic combination with amikacin 15 to 20 mg per kg every 24 hours. Thank you.